This episode of GT the Podcast is supported by Alcon. This special episode of GT the Podcast is brought to you by Santen Pharmaceuticals Company. MicroShunt is CE marked in Europe and approved in Canada by Health Canada, marketed under the trademarked brand name PreserFlow. It is not yet approved in the United States and is pending PMA approval from the US FDA.
Hey everyone, it's Ike Ahmed. I'm pleased to introduce our podcast on MicroShunt Pearls Lessons Learned. With me here today, I have two surgeons who've had a lot of experience in the world on the MicroShunt over the last few years. We have Ticiana De Francesco, who's from Fortaleza, Brazil, and we have George Durr from Montreal, Canada. And between all three of us, we hope to share with you some of our lessons that we've learned over the last few years on success and pearls with the MicroShunt, both preoperative, surgical, intraoperative pearls, as well as post-operative suggestions as well. So to kick this off, I want to speak about patient selection. And Tissy, for you, who is the ideal patient for the MicroShunt?
So I believe the ideal patient for the MicroShunt is a patient with open angle glaucoma with IOP above target despite maximal therapy, and that the patients need an IOP in the IOP target on low teens. I think this would be our target patient.
I agree, Tissy. I think the one thing we've seen based on publications here is that I think the ability to reach a pressure pretty consistently down to around 13, 12. And I think that's the kind of target we're looking for. And so ideally somebody who needs that, which is often patients who have moderate to glaucoma and progressive glaucoma as well. George, there's certain things that we think about anatomically when it comes to patient selection. What type of things do you look for in examination, specifically in planning for the MicroShunt?
Yeah, so it's really important to look for a bunch of different things and cues on the exam, including conjunctival mobility, the redness preoperatively, where we want to implant the MicroShunt, whether we're going to try to aim typically more supraronasally, but if there's some scarring or some other area that's a little bit less amenable to perfect surgery, then we want to try to aim for that. And gonioscopy is really important, making sure if we have an open angle or a closed angle. So this is something that really needs to be checked preoperatively. And finally, eyes that are deep make it a little bit more difficult for implantation. For any glaucoma surgery, it's more challenging, but this is something to really consider preoperatively to try to account for that when you're in surgery.
It's a good point, George. I like that point because, we do like to work somewhat deeper into the fornix when we do our dissections. And so when it's a deep set eye or a difficult access, it's good to just know that ahead of time, plan what you can do, and we'll share some pros with regards to positioning. So Tissy, we often talk about the importance of conjunctival optimization, how to prepare the patient before MicroShunt implantation. What are your pros on this area?
Yeah, I think this is very important to have like a surgical success. And one of the steps that we usually focus is to start the patient on steroids 4 times a day, 1 week before surgery. And also, if we notice that the patient has a lot of conjunctival redness, we consider to stop some of the glaucoma drops, and we start the patients on acetazolamide, oral acetazolamide, to decrease conjunctival redness and improve the ocular surface.
Yeah, I mean, I'm a huge believer in that, Tissy. I hate operating an eye that's red, and even microscopically, subclinically, there is likely to be some subclinical inflammation, as we know from various studies. So I really like the idea of prepping the eye by treating with anti-inflammatory medications, lid, margin treatment if necessary as needed. And yeah, I think stopping glaucoma medications if they're potentially toxic or irritating and using oral CIs is great. So I totally agree with those points. I think we've summarized nicely some of the preoperative considerations for the MicroShunt to optimize results. I wouldn't minimize that because we often focus on surgery, but preoperative prep and optimization and selection are very important. So listen, let's move forward and talk in terms of talks about surgery, because this is a clinic everybody wants to hear about. There's no doubt that, there's a variety of different approaches. We're going to be talking a bit about our own opinions and our own experience, of course. The U.S. clinical trial has specifically a protocol, and we'll describe it. and hopefully add a bit of flavor based on our own experience. So I want to start off with George. An area that I think isn't often discussed is how do you approach the surgical site? I wonder if you can share some pearls about optimizing exposure, which I think is really critical to get the right placement here.
Yeah, this is so key in getting the proper positioning to be able to implant the device safely and consistently. Putting in a traction suture is really important to be able to get the proper area exposed. You want to make sure that that your head is positioned in a way that it's a little bit tilted towards the surgeon. Find having a little bit more of the head towards us helps us get a better view of that area where we're going to implant the microshunt. And then you got to think whether you're going to go supratemporal or supranasal. It's better to avoid going directly at noon to avoid getting in that superior rectus muscle, but just going either around 1 o'clock or 11 o'clock may be a little bit easier for your exposure and your further risk of scarring down the road.
George, you've hit a lot of pros. I completely agree with optimizing the visualization. I think, I used to start sitting at 12 o'clock when I started with microshunt implantation. I very quickly moved to temporal, sitting temporal like I do for phaco. I find that it allows me to look directly into the quadrant, typically supranasally, that I'm going to be working in. I also think that, having the patient's chin up, meaning their head, positioned up, allows me to look into that quadrant. I mean, visibility is so important to see where we're dissecting and see where microshunt implantation is placed. So yeah, I think that is a great way to start surgical pearls. Of course, the first step, Tissy, is how to open conjunctiva and tenons. I wonder if you can share your pearls on that aspect of the procedure.
So when we're doing this microshunt surgery, we usually perform a small 2 clock hours conjunctival peritomy in either the supranasal quadrant or supratemporal quadrant. And we also perform one nasal radial incision so we can have a better view, a better posterior view. It's also very, very important. It's one of the key steps of the surgery is how to handle the tenon. So we have to handle the tenon very, very gentle to disinsert the tenon of the sclera and the conjunctiva and divide the two layers, divide the tenon from the conjunctiva.
Yeah, I'm glad you talked about tenons because I, not to be provocative, but I think tenons management to me is one of the most important pearls for success with this procedure. And I like you, I like to kind of open conj first and then disinsert tenons, which is typically 1.5 millimeters back from the limbus, disinsert it and then dissect bluntly, being mindful that there still may be some adhesions posteriorly. And so be careful to lift it all up anteriorly, and then one can dissect bluntly posteriorly. And a pretty posterior dissection is important. And as you said, make it. I don't think there's anything wrong making a good sized peritomy. I think it allows us good access and good visibility. I'm not a fan of making a very small peritomy and then being handcuffed by having a very difficult view. So I think those are important points to sort of emphasize here. And like you said, I think a fornix-based peritomy is ideal. We don't want to have an incision posteriorly where it could scar over.
Yeah, I think talking about that tenons handling is particularly key because it's so hard to get caught while you're dissecting, not being sure where tenons is exactly, and grabbing and snagging tenons and making it small little strands of tenons. It's hard to really get that proper grab and stay with that grab of tenons. It gets you to control the eye better, to get you in the proper position. And it really gears you up for success in the long run in doing these procedures.
Yeah, agreed. And I think, there's a lot of debate, and I think, we've published on this topic as well about mitomycin. I wonder, George, if you can just give us some thoughts about mitomycin and, dosing, how it's applied. We know this, maybe you can review what the US study used, and then maybe you can talk about, your experience.
Yeah, so the study was using a dose of 0.2 milligrams per milliliters with sponges, and they had those for 2 minutes, if I'm not mistaken, during the on-label study. In our experience, we kind of changed the dosage a little bit. We have a couple of publications that came out, one in AJO and the other in BJO, looking at higher doses of mitomycin, 0.4 milligrams per cc. and putting him on sponges and even injecting an extra dose of mitomycin at the end. The sponges were for 2 minutes as well. And I think, making sure that those sponges are in the proper position, spreading out as much as possible posteriorly, so we promote that more posterior flow for the microshunt, are key steps in the way that we address scarring and healing. And we know that whenever there's a bleb, there's going to be scarring down the road. So we have to try to decrease the potential of that happening, and having mitomycin in the right spot is really key.
Yeah, George, our studies, again, referencing both virgin and refractory eyes, showed that when we increased the mitomycin beyond 0.2, that was one of the biggest factors for success. And so we have really moved completely away from 0.2 and really only use 0.4 milligrams per cc or higher with sponges and even injection, as we've talked about, which of course is off-label. Tici, I think the next step that's critical is the scleral tunnel creation. And I wonder if you can maybe just review a couple of different techniques and the principles behind that.
Yeah, so we usually perform the scleral tunnel 3 millimeters from the blue zone. And there are like two different ways to perform this scleral tunnel. One way is to start to perform the scleral tunnel with a microknife until like 2 millimeters close to perform 2 millimeters of the scleral tunnel with the microknife, and then get into the AC with a 25 gauge needle. And other way is to use the DSK microknife, and we can use this knife to both create the scleral tunnel and also get into the AC.
Yeah, I think one of the important points is that we want to, of course, end up with the shunt, in the AC in the iris plane, ideally entering the anterior chamber at the anterior trabecular meshwork. To do that, though, of course, we can't start in that plane when we're outside. So we basically kind of tunnel in the sclera. I like to say a 20-degree, downward trajectory for 2 millimeters. And then at that point, we stop and then we go to the 25 gauge needle. And with that needle, we want to basically make sure we're entering iris plane. People use different landmarks. I think, by going 3 millimeters back from the limbus, that you're going to tunnel forward 2 millimeters, that leaves you at the end of the blue zone, which is basically where you want to be. And I think that knowing where the limbus is and the blue zone are two important landmarks. And I really recommend some wet lab experience when starting this procedure to just appreciate the different angulations that you have to achieve. It's very much like doing a tube shunt where we basically use a needle to enter the eye from a 3 millimeter tunnel, and we have to change the direction. I also want to make one final point, which I think is important, is we don't want to make that two planes too angled. In other words, we don't want to pinch the implant. And so a more gradual plane, I think, is ideal. And I think going 2 millimeters forward, but making sure you're not totally scleral plane. You're kind of going a little deeper as you're progressing, 20 degrees angle down, then stop, and then make sure you enter iris plane by lifting up the heel and putting the tip at the iris plane. Using countertraction with traction suture is helpful. So I think those are important points. And as Tici said, there's two different ways that one can use to do it right.
This episode of GT the podcast is supported by Alcon.
And Ike, if you want to try to, if you're not happy with the first tunnel that you've created, you can just create another one next to it. In our experience, we haven't found a lot of leaks from those first tunnels. So it's not a bad idea if you're putting the implant in and saying, hey, this is like pointing up towards the cornea or too much towards the iris, then you want to reposition it by creating another tunnel altogether.
Great point. Okay. Next point, we do want to make sure that we assess for flow. And that to me is one of the points where I do look for, flow from the tube. George, can you kind of go into a little bit more what you like to do to assess that?
Yeah, so it's really important to create, first of all, a paracentesis incision with one of the microknives that's provided, and then to hyperinflate the anterior chamber. So get your pressure really high, and then look at the flow through the device. There should be a steady and quick percolation of BSS basically through the tip of the device, and then bring the pressure all the way down single digits, and C, and there still should be flow, but it should be a lot slower. If you're noticing a big difference in the flow rate, especially at high pressures, and you're thinking, oh, this is going slower than what I'm expecting, then you have to think of all sorts of different causes that could be blocking the microshunt. It could be a pinching of the device. It could be pigment within the lumen. Is it iris that's obstructing the implant? You really have to go through your differential, examine the implant, sometimes just remove it all the way out and look at it, make sure that there's nothing within the lumen. And you can even flush it with a 23 gauge cannula, a thin wall cannula. You go around the tip of the implant that's out on the conj, and you just forcefully inject BSS through the implant, and it really allows for that flow to be reestablished. Sometimes just a simple flush on the operating table can relieve any obstruction.
Yeah, and that's why I think it's nice to have a paracentesis made where you can inject BSS into the eye and assess for the flow. We like to kind of increase the pressure just into the mid to high 20s. And I totally, as George said, I mean, look for like a beep, 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 like a steady flow that comes out of that tube, which can be, either directly or can basically, go along the shaft of the implant, and then do the same thing when it's low. And if you don't see that, I recommend to really, as George said, make sure that you flush the tube or check for any obstruction. So we're happy now. We've got a good placement here. We talked about how you open conjunctina. Tissy, how do you close the tissue?
So we usually perform a two-step wound closure. First, suture the tenon, and before suturing the tenon is very important. It's important to make sure that the implant is free and is not stuck in tenon. And after suturing the tenon with 2 interrupted sutures, we also suture the conjunctiva with 2 wing sutures, and then we also do 1 interrupted suture in the area that we did the radial incision.
Yeah, I think that's exactly as you said. And I think, that radial helps us to visualize, to make sure when tenons is being drawn forward, that it's not, caught on the implant. And you want to tuck that implant, as they say, tuck it under the sheets there without getting trapped. And that visualization is so helpful to evaluate for that. Sometimes there's a fold of tenons as you bring it forward, they identify and grab and bring it forward to make sure it's not catching the implant. I think that's, important to ensure free flow and reducing the distal resistance. And I love the 2-layer closure, as you said, Tissy. We typically use 9.0 Vicryl, but you can use whatever your preference is. Okay, great. Listen, that was fantastic to review the surgical pros. There's obviously a lot more to it, but I think Tissy and George have really hit the highlights. Let's quickly go through some post-operative care pearls. George, what's a typical course and expectation for pressure and visual recovery in the first few months after surgery?
So typically the post-op day 1 pressures are about 6 to 8. At about 4 to 5 days, you get a pressure between 6 and 10. At week 1 or 2, you're about between 8 and 12. And then from post-op month 1 to about post-op month 3, you're about between 10 and 12, sometimes even in the single digits. And it typically stays around that course during the first year. And this is what we found in our publication in the standalone study, in the refractory study. And the visual recovery is quite fast. Within the first few days, the patients typically have a good recuperation of their vision and don't have a lot of visual difficulties afterwards.
Thanks, George. Tissy, what's a typical post-operative regimen medically?
In the post-op, we usually use the steroid every 2 hours for the first week, and then we taper down to 4 times a day. We use 4 times a day for the first month, and then we're tapering down every week. And also in the post-op, we use NSAIDs, but it's very important to make sure that the patient does not have any leakage anicidal, because if the patient have any leakage, we need to hold on the NSAIDs and then to restart later on.
Yeah, I mean, like we spoke about preoperatively, controlling inflammation is so important to postoperative success and prevention of scar formation. George, what about the role of prophylactic anti-fibrotic injections?
Yeah, so I think that's really key to avoid any excessive scarring, or if you're getting a lot of inflammation or inflamed blebs, to inject some 5-FU, and you can do that quite readily in the early postoperative phase to control that scar tissue formation. And mitomycin C can also be used prophylactically or just at the time of needlings to help avoid any fibrosis in the later stages.
Yeah, I find myself using 5-FU maybe a bit more than I did a few years ago, especially in the early postoperative period. If we find excessive vascular tortuosity or thickening of the bleb, prophylactic injections I think are helpful, and we often will do it 2 or 3 times in the first month to be sure we can address that. Now, what about dealing with early acute IOP elevation in the first days or weeks after the procedure? TC, what are your thoughts about diagnosing and managing that?
I think, first of all, I think it's important to determine if this IOP spike is happening in the first days, or maybe like weeks after. Because if it's happening in the first days, I would suspect more of a device obstruction than a bleb fibrosis. But if this IOP spike would happen a few weeks after surgery, then I would suspect more of bleb fibrosis. And of course, if we think that the patient has, if we think that there is any obstruction in the device, we should consider a tube flush. Or if we think that there's any bleb fibrosis, then we would consider needling.
So I agree, Tissi. I think, when you have an early IOP rise, this is typically a lumen obstruction, which you can consider whether it's an internal lumen obstruction, for example, blood, pigment, inflammation, viscoelastic if it's used, or external compression, perhaps where the angulation of scleral tunnel has been more acute than we like, and the implant may be pinched. And a digital ocular compression or massage in the early postoperative period can be very helpful to relieve internal obstructions. And I recommend that. I agree. If it's pressure's high in the first few days, a flush can be done again with a 23 gauge thin wall cannula, as George mentioned earlier, intraoperatively. That can be done ab interno through the anterior chamber as an option to do that as well. So those are good thoughts about early pressure spikes. But as Tissi said, when the pressure elevates later in the postoperative period, weeks to months later, this is often due to bleb fibrosis. And so in those situations, George, what are your thoughts in terms of managing bleb fibrosis?
Yeah, so fortunately, we don't need to needle that often. In the published study by Schlenker et al. And Durr et al., with the standalone study and the refractory study, we found needling rates of about 5 to 10%. And the way that we go about these is by using a 25 gauge MVR blade that has cutting on both sides of the blade to be able to sweep under and over the implant to cut that fibrotic tissue that is formed under the implant and over it, and sweep it posteriorly into the fornix. And this is really something that allows for trying to reestablish flow at the tip of the implant. They are more challenging compared to other needling, for example, a trabeculectomy. But if you use like those bigger needles as the MVR blades, for instance, it makes it a little bit easier to cut through that thick scar tissue. And also when that doesn't work, or if you're a few months out and you've had a little bit of a rougher postoperative course with the fibrosis, then you may need to revise these implants, which is also in the two studies that I stated earlier, around 2 to 3%, where you basically open up conjunctiva and you dissect off all that fibrotic tissue over and under the implant, add some mitomycin C, and then close in a single closure.
Yeah, I mean, our studies have shown about a less than 10% needling rate. And I will say that needling the MicroShunt is more challenging than needling a trabeculectomy, where you can needle under the flap and enter the AC. You got to kind of visualize well enough, and ideally, sweep underneath the implant and then swipe toward the fornix and literally like use it at cutting edge. And that's why the MVR, 25 gauge MVR blade, as George said, is helpful to do that, because it's got a side cutting edge. It's a lancet blade rather than a beveled needle tip. But we try that usually. I have to say, we're probably about a 60, 70% success rate on needling, as we've shown. And then if that isn't enough, then we do a bleb revision, which is an open revision procedure. We have had reasonable success in doing the bleb revisions in this manner. And we typically open conj and remove the scar, reestablish flow, flush if we need to, and can use other adjuncts as well, particularly mitomycin C. So I always try to revise, and I think it's been a useful tool post-operatively. Listen, it's been a fantastic conversation with both of you. I thank you, Tissi, for joining us. I thank you, George, for joining us. You two have had some of the most wide experiences with the MicroShunt, and sharing your pearls are important. What we've discussed are important preoperative considerations to promote success, some of the important critical surgical pearls, and then some post-operative suggestions as well. The MicroShunt has been an important tool in our chest of options for patients, reaching target pressures typically down in that 13 to 12 millimeter range, as we've shown in our publications, with typically less post-operative visits and a more rapid visual recovery and a stable pressure control, which makes it as an option for patients who need a significant pressure drop in this manner. I hope these pearls have been helpful for you. And as anything else, a big part of surgical success is the surgeon himself, and we hope this has been helpful. So thank you very much for joining us.